Hi and welcome back. Today in this video we will start a new chapter in anatomy, orbit and its context. This chapter is considered to be one of the difficult ones in head and neck to grasp, especially the relations between the numerous delicate structures here. I will try to simplify it with a 3D model. We will cover this entire chapter in 3 videos. This video, the first in the series, deals with bony orbit and extraocular muscles. In the next one, we will discuss nerves and vessels of orbit, and in the final one, hopefully, we will deal with lacrimal gland and ciliary ganglia. Okay, let's dive into the video. Orbits are 2 bony cavities on either side of the root of the nose. They are roughly pyramidal in shape, with the apex, which is the posterior end of the orbit, and the base, which forms the orbital opening. They have 4 walls: roof, floor, lateral wall, and medial wall. We will discuss the formation and features of each wall separately. For better visibility and clarity, we will paint each of the bones which form the orbit in different colors. First, we will start with roof. The roof is formed by the orbital plate of frontal bone and the lesser wing of sphenoid. It is related to the anterior cranial fossa above and the frontal air sinus, which is anteromedial in position. Features in the roof include the lacrimal fossa, which is present anterolaterally and which lodges the lacrimal gland, the optic canal, which is posterior, the trochlear fossa, which is present anteromedial and which provides attachment to the fibrous pulley through which the superior oblique muscle passes. Here, remember, the lacrimal fossa is lateral and trochlear fossa is medial. Lacrimal fossa lateral, L. Don't get confused on that. Lacrimal fossa is anterolateral and trochlear fossa is anteromedial. Now moving to the floor of the orbit. The floor is formed by the orbital surface of maxilla and parts of zygomatic and palatine bones. The relations include maxillary sinus, which is present underneath the floor, and the features include the inferior orbital fissure, which opens into the infratemporal fossa and pterygopalatine fossa. Pterygopalatine fossa medially and infratemporal fossa laterally, and the infraorbital groove, which is present in the floor of the orbit. The lateral wall is formed by the greater wing of sphenoid and orbital surface of the frontal process of zygomatic bone. Coming to relations, the part formed by the greater wing is related to middle cranial fossa, and the part formed by the zygomatic bone is related to temporal fossa. Coming to the features, it has 2 openings, the superior orbital fissure and the foramen for zygomatic nerve. The medial wall is formed from before backwards by the frontal process of maxilla, lacrimal bone, the orbital plate of ethmoid and body of sphenoid. Coming to the relations, it is related to the nasal cavity and ethmoidal and sphenoidal air sinuses. Coming to the features, it presents the lacrimal groove, which is present between the lacrimal crest of maxilla and the crest of lacrimal bone. It lodges the lacrimal sac. Anterior and posterior ethmoidal foramina are present along the line of the frontoethmoidal suture. Here, remember, the orbit, being pyramidal in shape, is not placed directly forwards. The long axis of the orbit is directed backwards and medial. You can see that better from a top view or from above. When seen from above, you will see that the medial walls are parallel to each other, but the lateral walls are at right angles to each other. So, the long axis is directed backwards and medially. But remember, the eyeball is not placed in line with the orbit. It is placed directly forwards. There is something called a visual axis and orbital axis. The visual axis is the axis passing through the anterior and posterior poles of eyeball, and the orbital axis is the axis passing through the optic canal and the center of the base of the orbit. This visual axis makes an angle of 20 to 25 degree with the orbital axis. The contents of the orbit include the most important one, that is the eyeball, the fascia, both orbital and bulbar, the muscles, both extraocular and intraocular, vessels, which includes ophthalmic artery, superior and inferior ophthalmic vein, and lymphatics, the nerves, which include the second cranial nerve, that is the optic, the third oculomotor, the fourth trochlear, the sixth abducent, and the branches of first and second division of trigeminal nerve. Apart from this, it includes the lacrimal gland, of course. All these delicate structures are well protected in the cushioning of orbital fat. Okay, now that we are thorough with the bony orbit, let's move on to the actual topic of today's discussion, that is extraocular muscles. Just like any other muscle, we will discuss these extraocular muscles under the following headings: origin, insertion, nerve supply, action, and clinical anatomy. When I say extraocular muscles, it includes both voluntary and involuntary extraocular muscles. So when the question is about extraocular muscles, your answer should include both voluntary and involuntary muscles, not just voluntary muscles. The extraocular muscles are divided into voluntary and involuntary group. The voluntary muscles include the four recti: superior rectus, inferior rectus, medial rectus, and lateral rectus, two obliques, superior oblique, inferior oblique, and levator palpebrae superioris. The involuntary muscles include superior tarsal, inferior tarsal, and orbitalis. Instead of seeing the origin insertion of each muscle separately, we will see them in a clubbed fashion. Coming to the origin, the four recti take their origin from the common tendinous ring of Zinn. Here, you can see a tendinous ring encloses the optic canal and part of the superior orbital fissure, thereby dividing the superior orbital fissure into three parts: the lateral, medial, and medial part. The recti, four of them, take their origin from this common tendinous ring of Zinn. Lateral rectus alone has an additional origin from the greater wing of sphenoid lateral to the ring. The superior oblique takes its origin from the lesser wing of sphenoid superomedial to the optic canal. Inferior oblique takes its origin from the orbital surface of maxilla. The levator palpebrae superioris takes its origin from the lesser wing of sphenoid at the position antero-superior to the optic canal. Coming to the insertion, the four recti insert into the sclera a little posterior to the limbus, that is the sclerocorneal junction. The superior oblique first passes through a fibrocartilaginous pulley which is attached to the trochlear fossa, then passes lateral, downwards and backwards below the superior rectus and inserts into the sclera behind the equator of eyeball between the superior rectus and lateral rectus. The inferior oblique passes lateral upwards and backwards below the inferior rectus, then deep to lateral rectus, and it is inserted close to the superior oblique a little below and posterior. The levator palpebrae superioris is different from others in the sense that it does not insert into the eyeball, instead it inserts into the upper eyelid. This levator palpebrae superioris splits into superior voluntary and inferior involuntary portion. The superior voluntary part is inserted into the anterior surface of the superior tarsus, that is the upper eyelid, and inferior involuntary part is inserted into the upper margin of superior tarsus and also to the superior conjunctival fornix. Okay, now that we have discussed the origin and insertion of muscles, let's move on to the nerve supply. In order to remember the nerve supply, I use a formula, something similar to a chemical formula you might be familiar with from chemistry of your school days. The formula is SO4, I think that's the actual formula of sulfate. Yes. Okay, so the formula here is SO4 LR6O3. O3 is again ozone. So the formula is SO4 LR6O3. Let me explain what this formula refers to. SO4 is the superior oblique is supplied by fourth nerve, that is the trochlear nerve. LR6 refers to the lateral rectus is supplied by sixth nerve, that is the abducens nerve. And O3 is all the other muscles are supplied by the third nerve, that is the oculomotor nerve. Of course, in order to use this formula, you must be thorough with the cranial nerves numbered, which I suppose you all are. Now let's add these nerves to our 3D model. So our fourth nerve, that is the trochlear nerve, supplies the superior oblique. The sixth nerve, that is the abducens nerve, supplies the lateral rectus, and the others are supplied by oculomotor nerve. This oculomotor nerve has two divisions, upper division and lower division. The upper division supplies the superior rectus and levator palpebrae superioris, and the lower division supplies the other three muscles, that is the medial rectus, the inferior rectus and inferior oblique. Here it is helpful to remember an additional point which will help you in drawing the diagrams for your answers. As I told you earlier, the ring of Zinn divides the superior orbital fissure into three parts, the lateral, middle and medial part. The trochlear nerve enters the orbit through the lateral part. The two divisions of oculomotor nerve enter through the middle part. The abducens nerve also enters through the middle part, but it is placed inferolateral to the oculomotor nerve. It helps to remember this information while drawing the diagram. Now coming to the actions, which is the trickiest to remember in this particular topic, we will simplify that by discussing it in an organized way with the help of a diagram. First, we will see what are the possible movements which can happen. In the eyeball, movements are possible in three axes. In the transverse axis, the movements possible are elevation and depression. In the vertical axis, the movements possible are adduction, that is medial rotation, that is moving the eye towards the midline, and abduction, that is lateral rotation, that is moving the eye away from the midline. Along the anteroposterior axis, the movement possible are intorsion and extorsion. So in transverse axis, elevation, depression; in vertical axis, adduction, abduction; and in anteroposterior axis, intorsion and extorsion. These are the possible movements in the eyeball. But remember, pure isolated movements are rare in eyeball. Most of these movements are combined and conjugate. Conjugate movement refers to the combined paired movement of both eyeballs. For example, when one eye adducts, the other eye abducts. And this happens vice versa. That is, when one eye abducts, the other eye adducts. Just like wiper blades in car. And this is called conjugate movement. So, as we saw, 6 movements are possible in eyeball. The trickiest part is knowing which muscle brings which movement. There are 2 ways to approach this. Either try to memorize the muscle and movements brought by them, or what I use is try to grasp it and remember with the help of a diagram. I will show you how. Let's drop our eyeball here. The first thing to do is fix the side, because the medial and lateral sides change with which side the eye is. From viewer's perspective, medial is to the right hand side of the viewer in a right eye, while in a left eye it is to the left hand side of the viewer. So to avoid confusion and a costly mistake, the first thing we will do is fix the side. I will fix this as a right eye, which we had been following all along. For the right eye, this is the nose side or medial side, and this is the ear side or lateral side. So once that is fixed, let's draw 2 arrows, one at each side, medial and lateral. Add 3-way arrows on 4 corners. Remember another thing here, these curved arrows should face each other medially and laterally, not superiorly and inferiorly. With this method, any mistake in diagram can render your entire answer wrong. So don't make such costly mistake. Okay, now that you know how to draw the diagram, now add the muscles to these arrows. Medial rectus to the medial arrow, lateral rectus to the lateral arrow. There is no confusion in that. When it comes to the other recti and oblique, remember two rules. Rectus is always medial. Oblique is lateral but inverted. Something like rectus medial, RM, oblique lateral but inverted, OLI. What that means is rectus medial. So add a rectus to the medial side. That is superior rectus here and inferior rectus here. Oblique lateral but inverted. So add inferior oblique above here and superior oblique below. Okay, here the inferior oblique comes above and superior oblique below, inverted. Now you are in a position to derive the actions from this diagram. How? Let me show you. From this diagram, it is clear that elevation is represented by these two arrows. So elevation is brought about by superior rectus and inferior oblique. Depression is brought about by these two arrows. Depression by inferior rectus and superior oblique. Adduction is represented by, adduction is medially, bringing the eye medially. So adduction is represented by these three arrows. So adduction is brought about by superior rectus, medial rectus and inferior rectus. Abduction, which is taking the eye towards the lateral side, is brought about by lateral rectus, superior oblique and inferior oblique. Intorsion is represented by these two curved arrows. Intorsion is brought about by superior rectus and superior oblique, and extorsion is brought about by inferior rectus and inferior oblique. So if you make this diagram correct and you know the rules, that is rectus is medial and oblique is lateral but inverted, you can easily derive the muscles and the movements produced by them without any memorizing. Usually I use this method. You can use whichever you are comfortable with. Okay, now as I told you, a discussion on extraocular muscles is not complete without discussing involuntary muscles. As I told you, there are three involuntary muscles: superior tarsal, inferior tarsal and orbitalis. Superior tarsal is nothing but the deeper portion of levator palpebrae superioris. We saw that the levator palpebrae superioris divides into a superior voluntary and inferior involuntary part. The inferior involuntary part is the superior tarsal muscle. It inserts into the upper margin of superior tarsus, as we saw, and the action is it elevates the upper eyelid. The inferior tarsal muscle originates from the facial sheath of inferior rectus and inferior oblique, and it inserts into the lower margin of the inferior tarsus, that is the lower eyelid. The action is possibly depresses the lower eyelid. As you know, in human beings, the movement of lower eyelid is not that significant. The action of inferior tarsal is possible depression of the lower eyelid. Coming to orbitalis, it bridges the inferior orbital fissure, and here the action is uncertain. Okay, now moving on to clinical anatomy. The first clinical relevance we will discuss is squint or strabismus, which is caused by weakness or paralysis of one or more of extraocular muscles. As I told you, there are 6 extraocular muscles on each side which bring about the movement of eyeball, the 4 recti and 2 oblique. There are 6 muscles on each side which bring about the movement of eyeball, which are supplied by 3 nerves on each side. So totally 12 muscles and 6 nerves. That is 6 muscles and 3 nerves on each side, making 12 muscles, and 6 nerves have to act in unison to bring about proper movement of both eyeballs, that is proper conjugate movement of both eyeballs. If one or other of this nerve or muscle is affected, then squint or strabismus can be the result. Squint or strabismus can be concomitant or congenital. That is, it is present from the birth. In that case, there is no limitation of movement and no diplopia. The eye movement and vision is perfectly normal except for the looks. But as we know, the beauty or looks is a subjective matter. The usual thinking is squint or strabismus is not that great looking. But as you can see in this picture, there are handsome and beautiful celebrities who have squint. Now the other type of squint is paralytic squint. Is squint caused by paralysis happening later in the life. Here the eye movement is limited and there is diplopia, that is double vision, and vertigo, that is loss of balance, because vision is also a component of the mechanism which maintains the balance. And remember, here the head is turned to the paralyzed side. The head is involuntarily turned to the paralyzed side. The second clinical relevance we will discuss is nystagmus, which is involuntary rhythmical oscillatory movement of eyeball, as you can see here. This is due to incoordination of the eye muscles. As I told you, for a proper movement of eyeball, the 6 nerves and the 12 muscles supplied by these 6 nerves should be in perfect coordination. Okay, with this we will end our discussion on extraocular muscles. I will meet you very soon with my next video on the nerves and vessels of orbit. Until then, happy reading anatomy. It's Dr. Aravinth signing off. Thanks for watching. Bye.